Once they have stage 3 disease, do you all always get BRAF and PD-L1 testing, Omid? If you have a stage 3 patient in front of you that, say, Robert's already operated on, are you going to then see the patient and get BRAF testing at that point?
So, Jeff, for us, we try to do it on the majority of patients. Absolutely now, because of the decisions to be made in the adjuvant setting, the decisions to be made if we need in the metastatic setting. In the community, sometimes they're referred without the tissue available, and we would like to have that data in order to know and not delay if there is a metastatic recurrence. So for us, we discuss with the patient that most of the data will be used in the case of metastatic disease, but we do get that data. Ultimately, some of the other mutational analysis that's done can help us with phase 1 and other therapies down the line.
Okay, but it sounds like it's mostly you're going to get it, but it may not impact on your immediate management. It may help you somewhere up the road if they do progress. And what about PD-L1? Does anyone routinely get PD-L1, Hussein?
Not really. So I want to comment on one of the challenges of testing BRAF in those stage 3 patients, especially stage 3As that may have thin primaries and only microscopic disease in the sentinel lymph nodes. So the availability of tissue is a very important aspect. But I completely agree with testing for BRAF and knowing that as early as possible in the patient's history. From the PD-L1 perspective, PD-L1 positivity has been associated with higher response rates, but PD-L1 negative patients still respond. So we really don't use that to make determinations of whether we should treat our patients or not. So I think if a patient is in a clinical trial, we make a point of actually testing PD-L1 in that setting, but we don't use it for clinical decision making, especially not in the adjuvant setting, to be honest.
And so, Michael, tell me about the practice-changing trials. There have been 3 trials that are large randomized trials that I think have been practice-changing that have matured in the last year, which is pretty remarkable in melanoma. So tell me about the data from these 3 trials.
It's been great, really. 3 positive phase 3 studies. One in BRAF-mutant patients, so it tested the combination of dabrafenib plus trametinib versus observation in stage 3A, 3B, and 3C resected melanoma. That study was very, very positive for its primary endpoint of recurrence-free survival. It also looked like overall survival was improved, although the statistics were a little bit kind of an early look, so it's hard to definitively say overall survival was improved, but I think clearly a very significant recurrence-free survival advantage. BRAF mutant patients getting dabrafenib, trametinib over observation. That was the first phase 3 study. The other 2 phase 3 studies that were positive were both PD-1 trials that tested in one study the PD-1 inhibitor nivolumab versus the CTLA-4 inhibitor ipilimumab, and that was demonstrating that nivolumab was better than ipilimumab. Not only better in terms of improving recurrence-free survival, but also better at reducing toxicities compared to adjuvant ipilimumab. So if you're deciding adjuvant ipilimumab or nivolumab for a patient, I think the answer is now clear. You should choose nivolumab because of the higher recurrence-free survival benefit and lower toxicity rate with adjuvant nivolumab. And the third phase 3 study that came out was testing adjuvant pembrolizumab versus observation. That study included stage 3A, 3B, and 3C melanoma patients. That was also positive for improvements in recurrence-free survival. So we have now a win for pembrolizumab over observation, a win for nivolumab over ipilimumab, and a win for dabrafenib and trametinib over observation alone. A little bit of different populations in some of these trials. So the nivolumab study had resected stage 4 patients and no stage 3A patients. Lots of kind of discussions and thoughts about interchangeability between these different agents. I think the bottom line summary is it's impossible to really tell a difference between nivolumab and pembrolizumab in the adjuvant setting in terms of efficacy. We don't really have head-to-head data, so it's really hard to say is dabrafenib and trametinib better than PD-1 in the adjuvant setting either. So I think some of those conversations are really tough. What do you choose for a BRAF mutant patient? BRAF-MEK, PD-1. If you have a BRAF wild-type patient, really your only choice is PD-1, at least over ipilimumab in observation, if you want to improve recurrence-free survival. We're still waiting on overall survival data, of course.
And then there actually was a 4th trial, which was the BRIM-8 trial, which we waited quite a while to see the results of. But again, is there anything that you can glean from those data that would either inform practice or help you to conceive of the next trial?
So the BRIM-8 was another phase 3 study testing vemurafenib as a monotherapy BRAF inhibitor versus observation. And that trial was interesting, a little bit different patient population than the other studies. One thing I would say is that the vemurafenib did show a biologic effect. It did look like it was better to have vemurafenib, but the way that the statistics were designed, it was technically not a positive study because it did not improve recurrence-free survival in the stage 3C resected group of patients, which was the first cohort that needed to be analyzed. I think all that to the side, the most important takeaway from that, for me, some activity of BRAF monotherapy, although if you're choosing BRAF-directed treatment in the adjuvant setting, you'd go with BRAF and MEK, dabrafenib and trametinib. But also interestingly, it included patients with stage 2C resected melanoma. So these were patients that did not have a sentinel lymph node involved with disease. And it is a reminder that that's a high-risk group of patients. 2C, thick, ulcerated primaries in many cases. And I think that that tells us that we need to test some of these drugs in stage 2 patients. And in fact, we have upcoming adjuvant studies of PD-1 drugs like pembrolizumab in higher risk stage 2 patients. So that could be a really big impact because a lot of the patients that recur to have stage 4 disease did not have stage 3 previously. They had stage 2 high risk disease or even stage 1. And that stage 2 trial is coming forward. It's a very important study.
If I could make a couple of practical points about that, I think those are all really well taken. I think a thing that comes up in my practice already started coming up as soon as this data became available is, do we know whether or not the patient has a BRAF mutation at the time that we're making the decision surrounding adjuvant therapy? So there's all of this great data for BRAF and MEK, and now with PD-1, but if you don't know whether or not the patient has a BRAF mutation, you really can't make that decision. And I think that that's something where our community needs to sort of reach back with our pathology and our surgery groups to really expedite getting that sort of information, because it's understandable that patients come in, obviously concerned, and, to tell them, you have to go away and come back because we have to do this test, it's less advantageous. Now, certainly that's a reasonable thing to do because this is kind of a big decision. There are toxicities associated with these treatments, and it's not something we want to rush into, but certainly I would advocate that having all the information at the beginning is better than not having it. And to the point about stage 2 trials, I completely agree. I think that there is a quite high-risk population of patients, which is actually much bigger than the stage 3 population, who potentially could benefit from some of these therapies, albeit we have to consider the toxicities and the number needed to treat here, because treating the broad swath of stage 2 patients, we really have to have a big impact there, otherwise we're potentially exposing a lot of patients to toxicity.